Hello friends, today we are going to discuss about the paracetamol poison. Paracetamol is an effective oral analgesic with the few adverse effects when used at recommended dose. Nevertheless, paracetamol poisoning is the common and potentially fatal. Potentially liver air damage predicted from the blood paracetamol concentration and the time from the ingestion can be prevented by the prompt treatment with the antidote. So recommended maximum doses of the paracetamol. For adult, it's 1 gram. Minimal dosing interval is the 4 hours. Maximum dose in 24 hour 4 gram is lethal. For children of 6 to 12 years of age, 2 gram maximum or dose of 2 gram in 24 hour is the lethal. For children of 1 to 5 years of age, 960 mg of dose is lethal. And for infants of 3 to 12 months of age, 480 mg dose is lethal. So mechanism of paracetamol poison. Mechanism therapeutic doses of the paracetamol are mainly metabolized by conjugation to the uh, inactive metabolite. Paracetamol predominantly diverts to the the reactive metabolite, the N-acetyl P benzoquinine, that is NAPQI, formed when paracetamol is oxidized by cytochrome P40 enzyme family, and it is a key to the hepatic injury. This NAPQI bind covalently to sulfhydryl group, which can be provided by the glutathione. But when glutathione stores are depleted, NAPQI binds to cellular protein. Toxicity is therefore affected by the rate of enzyme catalyze the formation of NAPQI, which can be induced by several drugs and chronic alcoholism, and by the availability of the glutathione, which depends crucially on the nutritional status. After covalent binding of the NAPQI to the cellular protein, cell injury is mediated by the free radical. An inflammatory response follows the cell death and may determine the outcome once the liver injury is established. So this is the pictorial representation of the mechanism of the paracetamol poisoning. So at therapeutic doses, the paracetamol is mainly metabolized by conjugation to inactive metabolite. A reactive metabolite, that is N-acetyl P-benzene quinine, that is NAPQI, is formed by the oxidation. So when large amount of paracetamol is taken, the more NAPQI is formed, and the sulfonation conjugation pathway is saturated, and NAPQI binds covalently to the sulfhydryl group. This can provide by the glutathione, but when hepatic glutathione stores are depleted, this NAPQI binds to the cellular protein and cause cell injury. So factor that increases the risk for liver injury after overdose of paracetamol. That is high chance of glutathione depletion. That is second risk factor is malnourishment, then eating disorder, failure to thrive or cystic fibrosis in children, AIDS, cachexia, alcoholism, then hepatic enzyme induction like long-term treatment with enzyme-inducing drugs such as carbamazepine, phenobarbital, phenytoin, primidone, rifampicin, rifabutin, efavirenz, nevirapine, and the stain zone wort. Regular consumption of ethanol in the excess of recommended amount. Clinical cues are history, abnormal liver function test, increased international normalized ratio, increased gamma glutamyl transpeptidase, abnormal renal and the liver function at presentation. Then about clinical presentation, many patients who present to so within few hours of taking overdose when symptoms and signs are absent or confined to nausea and vomiting. Lactic acidosis and coma can exceptionally occur soon after ingestion of massive amount of paracetamol. So their presence usually implies mixed overdose. Right upper quadrant tenderness is the common in patient presenting with established liver damage. Patient who present after 24 hours may already have sign of liver failure, hepatic tenderness, jaundice, impaired consciousness, asterexis, fetal hepaticus, and hemorrhage. Overt liver failure can, however, be delayed for 2 or 3 days. It is important not to overlook paracetamol in those who have signs suggesting overdose with another agent. How should the patient with suspected paracetamol poisoning be investigated? The history is crucial in patients who do not yet have liver failure because it determines the risk of severe liver damage and hence treatment strategy. About the dose of paracetamol. After single overdose, the patient may be able to say how many tablets have been taken. Difficulty arises when the tablet have been taken over period or if the patient is unable or unwilling to give relevant information. Now about time of ingestion. Knowing the time of tablet ingestion is crucial for calculating whether treatment with the antidote is needed. Because it takes some time to swallow a substantial number of tablets, take the start of ingestion as the relevant time if all tablets were taken during the period shorter than 1 hour, otherwise treat as a staggered overdose. In case of staggered overdose, more than one supratherapeutic dose, or if patient has been poisoned with intravenous or modified release formulation, decisions regarding treatment are more difficult. About physical examination as well as eliciting signs of liver damage from paracetamol, the examination may indicate that patient is more susceptible to developing such a damage. For example, because patient is malnourished. It may identify the previous liver disorder. About investigation, the crucial investigations are time, serum paracetamol concentration to determine the risk of liver damage and the test of liver function like prothrombin time and the INR and the kidney function. These tests are needed to assess the risk and the monitor progress. Prognosis is worse if they are abnormal at presentation. Paracetamol concentration in the venous blood should be measured between 4 and 16 hours after ingestion of the single dose to allow the patient's risk to be determined and from the standard normal. Values obtained earlier than the 4 hours cannot be interpreted because absorption is not yet complete. Values taken after 16 hours may be high because of the acute liver injury that delays the paracetamol metabolism or falsely reassuring, even though the reversible liver damage has been already occurred. In untreated patients with a negative taste for paracetamol and normal hepatic and renal function 24 hours after exposure, serious harm is unlikely. Ketone on urine analysis and low blood urea concentration can indicate starvation or poor nutrition, which increases the risk of liver damage. Raised gamma glutamyl transpeptidase activity is potentially useful indicator of hepatic enzyme induction. So, what is the initial approach to the treatment? Out of hospital, treatment depends on the adequate assessment, first aid measures, and transfer of at-risk patient for antidotal treatment. Activated charcoal taken soon after overdose should reduce the absorption of paracetamol. It is unlikely to help more than 1 hour after overdose. Now about acetylcysteine. The mainstay of the treatment for patients who have taken potentially toxic dose of paracetamol is antidote acetylcysteine, which is the sulfonyl donor. It is given intravenously in 3 sequential infusion, each containing different dose of antidote and is based on the patient's body weight. So up to maximum dose equivalent to the weight of 110 kg. So this is the recommended dose of acetylcysteine antidote in paracetamol poison. So it should be given in the 150 mg per kg in 200 ml over first 0.25 hours. Then in 50 mg per kg in next 4 hours in 500 ml. Then 100 mg per kg over next 16 hours in 1000 ml. So total dose is 300 mg per kg in 20 hours. Acetylcholine replenishes the glutathione store, which at least partly explain its antidotal efficacy. The large multicenter study of efficacy published in 1988 found that antidote is uniformly effective if given within 8 hours of single overdose, but subsequently its efficacy falls. A control trial provided evidence that um, acetylcysteine can improve outcome even in patient with encephalopathy. So those who present more than 8 hours after overdoses are still treated with antidote if they are deemed at risk of liver damage or if liver function is already abnormal. A retrospective cohort study of more than 4,000 patients showed that intravenous treatment is at least as effective as oral treatment but takes less time to administer. Intravenous treatment can be administered reliably even if a patient is vomiting. Finding from animal studies suggest that alternative sulfhydryl donor methionine is less effective than the acetylcysteine. Now the treatment normogram. The decision to treat paracetamol overdose with the acetylcysteine are based on the assessment of the risk of serious liver damage. The treatment normogram, originally derived from the study of just 32 patients, separates those who will develop serious hepatotoxicity, that is, transaminase activity of more than 1,000, from those who will not, on the basis of graph of paracetamol concentration against time from ingestion as it falls from 200 mg per liter at 4 hours. Healthcare profession can consult their poison information service for the treatment recommendation. The risk assessment normogram requires the time from ingestion to the known with reasonable accuracy. The efficacy of antidote declined from about 8 hours after overdose, so it is important not to delay treatment of potentially poisoned patient beyond 8 hours, even if paracetamol concentration is not. The normogram is misleading or unhelpful if the overdose was repeated or staggered, and if exact timing is unclear, and if patient is received intravenous preparation, because pharmacokinetic of such a preparation are different. In these circumstances, initial treatment decision has to be based on the total dose, taking any risk factor into account. Subsequently, abnormalities in the renal and hepatic function test will guide treatment. Now, this is the pictorial representation of the normogram, in which paracetamol concentration is showing on the y-axis and the time from overdose is shown on the x-axis. So, so the blue line represent the graph which is shown by the blue line. It's suggested by treat if paracetamol concentration is above this line in patient at risk is at high risk, and the line which are represented by the dotted red line, it indicate that we need to treat the paracetamol poisoning with acetylcysteine if paracetamol concentration is above this line in patient at normal risk. So, treating adverse event related to acetylcysteine. Acetylcysteine is a sulfurous and is commonly caused vomiting when given by mouth or nausea when given intravenously. It can also provoke the anaphylactic reaction, which is mediated by histamine and depend on the blood acetylcysteine concentration. Such a reaction may be more common in patients with asthma, those with family history of drug allergy, and female. Almost all reaction can be treated effectively by interrupting the acetylcysteine infusion and providing symptomatic relief with antihistamines such as chlorpheniramine and nebulized salbutamol if needed. In severe reaction where a patient becomes hemodynamically unstable, resuscitation may be needed. Once reaction has subsided, however, ensure that entire dose of acetylcysteine is given in due course, possibly at slower rate of infusion, that is at rate of 50 mg per kg per hour. Acetylcysteine has very rarely been associated with fatal adverse reaction. Some reported cases have been caused by miscalculation of the dose, which has led to overdose with the antidote. The risk of anaphylactic reaction is higher in patients with lower plasma concentration of paracetamol. This suggests that treating patients who are unlikely to benefit from antidote may cause increase the frequency of adverse reaction. What supportive treatment should be given? Fluid replacement and symptomatic treatment for nausea, vomiting are often needed. When acute liver failure has already occurred or seems likely, intensive supportive treatment and in appropriate circumstances, liver transplantation will be needed. A transplant is most likely to be successful if need for one is identified early. So criteria for possible liver transplantation: arterial pH less than 7.3, hepatic encephalopathy grade 3 or 4, and serum creatinine concentration more than 3, prothrombin time more than 100 seconds, arterial lactate concentration more than 3.5 on admission and more than 3 after 24 hours after paracetamol ingestion or after fluid resuscitation. How to manage the patient after administering antidote. Liver damage can be detected by measuring international normalized ratio, serum creatinine concentration, and liver function at the end of acetylcysteine treatment. Some units also measure paracetamol concentration because appreciable concentration can indicate a risk of continuing damage. UK guidelines, which have exploded from the study of acetylcysteine in encephalopathy, suggest that if international normalized ratio exceed 1.3 or transaminases have increased to more than double baseline values, then antidote should continue to be infused at the dose of 100 mg per kg over 16 hours until results are accepted. Patients with renal dysfunction after paracetamol poisoning require ongoing monitoring and may need renal support. Thank you, guys.